नमस्ते सबैजनालाई, मेरो नाम दुर्पता साउद, म नयाँ हेल्थ नेपालको सामुदायिक स्वास्थ्य कार्यकर्ता। विगत 3 वर्षदेखि म नयाँ हेल्थ नेपालमा कार्यरत छु। मेरो समुदायमा सामुदायिक स्वास्थ्य कार्यक्रम सुरु हुनुभन्दा पहिला स्वास्थ्य सेवा र स्वास्थ्य शिक्षा परोपकारी रूपमा समुदायमा र घर घरमा पुग्न सकेको थिएन। त्यसैले मानिसहरू आफूलाई भएको स्वास्थ्य समस्या आफू बाहेक कसैलाई पनि भन्न सक्ने अवस्था थिएन। साथै परिवार नियोजन के हो र यसका साधनहरू के छन् र यो कहाँ उपलब्ध हुन्छ भनेर पनि थाहा थिएन। त्यसैले थोरै समयको अन्तरालमा छिटो बच्चा जन्माउँदा र आफू सक्षम भएर नभएर बच्चा जन्माउँदा धेरै महिलाहरूको पाठेघर खस्ने समस्या भइरहेको थियो, जुन मेरो परिवारमा पनि म सानो छँदा मेरो हजुरआमाको पाठेघर खसेर निकाल्नु परेको थियो।
I'm Sabitri Sapkota. I work for Possible. I'm based in Kathmandu. Possible is a non-government organization. We collaborate with different organizations, including the government, for healthcare research and innovation. The situation that Durpata ji had just explained to us, this is very common in many remote and hard-to-reach areas in Nepal and outside. Basically, when we think about the mechanism to connect community people with health workers and health facility, there was no longitudinal mechanism in there. We wanted to have some innovative solutions to improve the life of women and the girls in there. So there was a global momentum that time around universal health coverage and a lot of discourse for the role of community health workers to achieving universal health coverage. Nyaya Health Nepal, where Durpata ji works, and Possible, we sat down together with our Ministry of Health and Population, its divisions, and the local government. We discussed about what we should do, and we conceptualized and designed this community health program. The community health program where Durpata ji works, it basically includes the community health workers who are from local community. They are trained, they get monthly salary, they are supervised and monitored by their supervisors. They use ComCare, which is a digital platform, and this is just not for the data collection. Community health workers, they use this platform as a guide for their counseling, care coordination, and referral. So this is the broader community health intervention program, not just like, focusing on contraception, but part of this broader intervention, Durpata ji and her team, they provide person-centered contraceptive counseling. Durpata ji, tell us, how do you normally do?
हामी समुदायमा ब्यालेन्स काउन्सिलिङ 15 देखि 49 वर्षको प्रजनन योग्य महिला, त्यसभित्रमा पनि गर्भवती महिलालाई चाहिँ गर्भको 8-9 महिनामा र सुत्केरी महिलालाई चाहिँ प्रत्येक महिना हामी ब्यालेन्स काउन्सिलिङ गरिरहेका छौं। ब्यालेन्स काउन्सिलिङ गर्दा हामी महिलाको स्वीकृति मन्जुरीनामा लिएर गर्छौं। कहिलेकाहीँ उहाँको श्रीमान तथा सासूहरूलाई पनि सँगै राखेर ब्यालेन्स काउन्सिलिङ गर्छौं। ब्यालेन्स काउन्सिलिङ गर्दा हामी विभिन्न कार्डहरूको प्रयोग गर्छौं र अन्तिममा महिलाले छान्नु भएको कार्डको बारेमा विस्तृत रूपमा जानकारी गराएर उहाँलाई चाहिँ त्यो गरिसकेपछि स्वास्थ्य संस्था रेफर गर्छौं र अर्को होम भिजिटमा चाहिँ हामी त्यो कार्ड प्रयोग उहाँले त्यो साधन प्रयोग गर्नुभयो या गर्नु भएन भनेर चाहिँ सुनिश्चित गर्छौं।
During the process of implementing this program, our program team, they sat with local people and they adopted and tailored that to suit the local cultural needs of the community. Once we rolled out this program for a year, we looked at the data to understand how the program is performing. So basically, we found that in a year time, women during the early phase of postpartum, they are 2 times more likely to use modern contraceptive methods. And basically, this is because they are using lactational amenorrhea method. Women are exclusively breastfeeding their babies, in 1 year period compared to before we started the program. We found that community health workers, they played a significant role in educating women, their partners, their mother-in-laws about different types of contraceptive methods and its side effects and ways to address these side effects. What was very, very insightful for us as a programmer is women, they wanted to be counseled, at home rather than at the health facility.
हामी समुदायमा चाहिँ काम गरिरहँदा विभिन्न प्रकारका चाहिँ चुनौतीहरू देखा पर्दछन्। त्यसमध्येमा पनि हामी कहिलेकाहीँ ब्यालेन्स काउन्सिलिङ गर्दा श्रीमान तथा सासूहरूले चाहिँ मेरो बुहारीहरूलाई बिगार्दिन आयो भनेर लान्छनमा लगाउनुहुन्छ। उहाँहरूको मन जित्नको लागि हामीलाई केही चाहिँ समय चाहिन्छ। त्यस पछाडि त्यो कार्यक्रमको बारेमा बुझिसके पछाडि, साधनको बारेमा बुझिसके पछाडि चाहिँ सबै कुरा ठिक हुन्छ।
Our program shows that community health workers like Durpata, they have played a significant role in providing sexual and reproductive health services at the community level, which ultimately helping us to achieving universal health coverage. This program is so very impactful and promising, but this can be adopted and iterated, sitting down with the local people, local government, and community leaders in order to match the needs of the local people. We have observed that this program has changed the lives of many women in this community and can also do the same for other women in remote and hard to reach areas in Nepal and elsewhere. One of the suggestions or one of the key things that they can take is we can design the program based on the evidence, which is which we can find in the global setting. But it is very important to sit down with the community people so that they can take ownership of this program. They can also adopt this program in order to suit the cultural and then the local needs of the people in there. And most importantly, the participation of different stakeholders in this program in order to make it successful and change the lives of people out there is very, very important. That's what we learned.